Assalamualaikum warahmatullahi wabarakatuh. So for today, I am going to present on my topic, which is about the gastric cancer. This is prepared by me, Muhammad Aidilfarez bin Amir Hazwani. So the contents that we are going to explain today is the first one is etiology, manifestation, pathophysiology, technical consideration, imaging modalities and radiographic appearances, complications, and then the references. So for the imaging modalities and radiographic appearances, I have merged it into one, so it is easier for me to explain the modalities itself and then show what does the modalities give us in terms of image that we can get. So we are going to proceed with the first one, which is about the etiology. So etiology means where does the disease come from. So in this case, gastric cancer are caused by Helicobacter pylori. So Helicobacter pylori infection has been demonstrated to be a major risk factor for development of gastric cancer. So besides Helicobacter pylori, unhealthy diet and lifestyle, including high salt food, smoking, and drinking, are also able to induce genotypic and phenotypic transformation of gastric epithelial cells. So the next one is the gene mutation, such as ecahedrin. In stomach epithelial cells are major genetic causes for genetic gastric cancer. Sorry about that. So next one we are going to talk about manifestation. So first of all, what is manifestation? So according to the medical dictionary by Farlex, manifestation means the display or disclosure of characteristic or signs of and symptoms or of an illness. So we know that manifestation means some things that we can see and some things the doctor can see when something happened to us. In this case, what is the manifestation of gastric cancer? So the signs and symptoms of stomach cancer may include difficulty swallowing, feeling bloated after eating, feeling full after eating small amounts of food, heartburn, indigestion, nausea, stomach pain, unintentional weight loss, and also vomiting. So next, we will go to pathophysiology. Pathophysiology, also known as pathogenesis, refers to how did the process of the disease happen. So the intestinal type of non-cardiac gastric cancer is generally thought to arise from Helicobacter pylori infection. This causes inflammation in the stomach. Researchers suggested that the long-term presence of an inflammatory response predisposes cells in the stomach lining to become cancerous. This theory is supported by the finding that increased expression of single cytokine in the stomach of transgenic mouse causes sporadic gastric inflammation and cancer. So this is how the researchers know that Helicobacter pylori, which is a type of bacteria, can be the one of the causes of stomach cancer or gastric cancer. The increased cell turnover resulting from the ongoing cellular damage could increase the likelihood that cells will develop harmful mutations. So, it initiates a sequence that progresses from chronic non-atrophic gastritis, and then it will go to atrophic gastritis. Next, it will go to intestinal metaplasia, and finally, it will go to dysplasia. This progression is known as the Corias cascade. Next, we are going to go to the technical consideration. So, technical consideration is more to the technical stuff on how we're going to do it, on how what is the KVP, what is the MMS, and what is the collimation, where is the part that we are going to scan in order to know more about the gastric cancer that might be in the patients. So the first one, if we are using the conventional X-ray, or in this case, we are using it with barium studies, the patient will be in a supine position. The patient projection in AP projection. So the centering point will be at the mid-sagittal place, which is equidistant from each ASIS at the level of the iliac crest. The collimation are laterally to the lateral abdominal wall, superior to the diaphragm, and inferior to the inferior pubic rami. So we know where is the area that we are going to shoot for the image. So next one, the orientation of the image receptor is in portrait. Next, the image receptor size is 35 times 43. We use the biggest one so that we can capture all the image in one in that one particular image receptor. So the exposure that is recommended is about 80 to 90 kVp, and the MAS is 30 to 120. So for the range of the exposure is a bit higher than normal because we have to do an addition type of X-ray. So we know that cancer usually is an addition type because it causes some addition of cells in our body. In this case, there's a addition of cells in our stomach. Because of that, the density will be higher. So it is required for us to increase the exposure a little bit so that we can get an adequate penetration. So the SID is 100 cm. This is to prevent the magnification of images because we don't want to misjudge the original size of the tumor itself. So next we need to use the grid because this is to prevent the noise from ruining the image itself. So next is the CT and PET scan. So the reason why I merged for this one is that CT and PET scan actually use the same modalities except for one, which is the contrast media itself. So CT scan will use the normal one, which is iodine if I'm not mistaken. And for PET scan, we are using radioactive substances, a radioactive glucose to be the contrast media. So in this case, the technical consideration for CT and PET scan that the patient will also still be in supine position. Put the patient's head on a pillow and the cushion under patient's knee so that they can feel comfortable. This is very important because this type of scan usually take a very long time. So define the FOV to include lateral margins of pelvis and use lateral scout to center FOV to include anterior and posterior margins of pelvis. The KVP will be 120 and MMS will be 200. Anatomical range for the scan is above iliac crest to mid symphysis pubis. So that is the scan range for CT and PET scan. Next one, we will go to the imaging modalities and radiographic appearances. So like I mentioned before, I have to merge it so that it will be easier for us to see. So the first one is the endoscopic ultrasound. This procedure is similar to the normal endoscopy, but the gastroscope has a small ultrasound probe on the end. So instead of just a normal camera to look inside the stomach, we have an ultrasound attached to it so that we can scan it so that it is easier for us to confirm there is a tumor inside the body. An ultrasound uses sound wave to create a picture of the internal organs. So instead of the radiation that we use for the conventional X-ray and also the CT scan and PET scan, ultrasound only use sound. Next, the ultrasound image of the stomach will help doctor to determine how far the cancer has spread into the stomach and nearby lymph nodes, tissue, and organs such as the liver or adrenal glands. So the next one is the conventional X-ray or barium studies. In this procedure, a person swallows a barium solution, then a series of X-rays are taken. So the barium coats the lining of the esophagus, stomach, and intestine, so the tumor or other abnormalities are easier to see on the X-ray. So this is pretty straightforward. The barium coat part that is the tumor because the tumor usually have a very irregular shape, and from that we can see the cancer. that exists in the stomach. But this method has a limitation. The upper gastrointestinal series may show the normal but thickened or enlarged gastric folds. It also may demonstrate a failure of the stomach to distend normally to air and instill barium. These barium studies also cannot help in making accurate disease staging. It also do not allow differentiation of benign from malignant lesion. Next modalities is the computed tomography, CT or CAT scan. So for this one, the CT scan take pictures of the inside of the body using X-ray from different angles. Computer combines these pictures into a detailed three-dimensional image that shows any abnormalities or tumors. CT scan can also be used to measure the tumor size. Sometimes a special dye called a contrast medium is given before the scan to provide better detail on the image. This dye is usually given both as a liquid to swallow and an injection into a patient's vein. So in this next picture, we can see how the CT scan helps with the detection of tumor inside the stomach. With the help of CT scan, we can see clearly where does the gastric cancer is. So in this case, it is near at the top of the images. So CT scan, like I said before, can demonstrate the size, the location, the thickness, the presence of fat, and also we can see with CT scan whether the cancer have invaded other places or not, like the nodal, vascular, or the visceral spread. But CT scan also have its limitation. It is unable to distinguish different layers of the gastric wall. Hence, it cannot differentiate between early lesions from the lesions that happen later. CT scan can also does not provide tissue confirmation for grading or typing. The ability to distinguish carcinoma from lymphoma is crucial to provide the correct therapy for patient. Next is the positron emission tomography or PET scan. A PET scan, like I said before, is a combination between CT scan and a PET scan. PET scan like CT, it can also be used to create a series of pictures of the organs inside the body. So in this slide, we can see how does the PET scan differentiate from the usual CT scan. With PET scan, we use a small amount of radioactive sugar substance which is injected in the patient's body. The sugar substances is taken up by cells that use the most energy. So, like we know, cancer cells usually takes the most energy for themselves. So, because of this, it absorbs more of the radioactive substances. And then a scanner then detects these substances to produce image of the inside of the body. So instead of just seeing the gritty part of the tumor, we can also confirm it further when using PET scan because it can highlight the part of the tumor with the radioactive scan. So next we will proceed with the complication. So complications related to gastric cancer are twofold. This means that if the cancer not treated, many complications will occur. These include pain, weight loss, difficulty swallowing, nausea, vomiting, and bleeding. The cancer may spread to the liver and cause complications such as jaundice, ascites, which means the fluid collection in the abdominal cavity, fever, and malaise. So, what about the complication after post-gastrectomy? The patients will often be immunologically deficient, as measured by blastogenic and delayed cutaneous hypersensitivity. So, uh, for those who might have patients or family that have a gastric cancer, you might want to take some precaution because even though after the gastrectomy, we still have some precautions that need to be taken. So I think that is all from me. This is the references from the sources that I use for my presentation. Thank you very much. Assalamualaikum.